For the session will be Idiculla sir and Dr Bindu Varghese. Also speakers will be Dr Gokul, Dr Shwetha and Dr Lakshmi. So without spending time, we will just invite the speakers and chairpersons to the stage and start the proceedings. Thank you.
Good morning, everybody. First of all, we would like to thank the management and Dr. Arun for giving us this opportunity to showcase some of our doings. We are going to talk about neurotology, that is balance and hearing. You know, this is nothing new. It has been happening for quite some time. People come to us saying that they have ear balance problems, and we have been treating it. Many of us have been treating it, and I say with certain amount of success. I mean, fair amount of success, but that was not a very scientific way of doing things. We have not been delving deep into the causes of vertigo or imbalance, and we've been treating with the beta-histine or cineracin, and most probably because they are self-limiting diseases, the patients were quite happy. But of late, we have been starting unraveling the mysteries behind what exactly causes this. What are the organs involved, what is the levels of the lesions, and then we have come to realize that things done in a more scientific manner gives better results to the patient. Same way with the hearing disorder. Children born with severe hearing deficit would grow up as deaf and dumb children, and there was nothing we could do to help them except advise hearing aids, which many times were not effective. But now with the advent of cochlear implant surgery, we are giving them a real chance at developing speech and integrating themselves into the society as useful citizens. So without further ado, I request Dr. Gokul to start with the proceeding, basics to beyond vertigo. Thank you.
Hello. Good morning, everyone. I am Dr. Gokul, Associate Consultant of Department of ENT, and I will be discussing the topic mainly vertigo, that is the very basics to a little beyond BPPV. As I told, the patient present to us with always this problem that I have ear balance problem. I have ear balance, talavarakam, and another doctor told that I am having ear balance problem and referred me to an ENT, like that. So we have been hearing this term multiple times a day, that is ear balance problem, ear balance problems. So what exactly is this ear balance problem? It just means the peripheral vertigo. They are just meaning the peripheral vertigo by ear balance problem. Whether the patient is having an ear balance problem or peripheral vertigo need to be diagnosed through the battery of history, examination and investigations. So every one of us, of all departments, will get patients with balance issues, particularly general GPs, physicians, ENT surgeons, neurologists, orthopedicians. Everyone get patients with balance issues. And each one of us have our own approach to dealing with these symptoms. We as ENT surgeons mainly stress upon this vestibular pathologies, and as I told, with or without a proper diagnosis, most of this patient will end up with either these drugs like vertigo, stemetil, or a cocktail of this. This is one problem. Another problem is different terminologies. They will tell different terms like vertigo, unsteadiness, dizziness, imbalance, head reeling, giddiness. So all these terms explain somewhat similar or same symptom. So in order to solve this problem, the Barney Society has come forward with a classification and proper definition of these vestibular symptoms and disorders. They have published that. Now we are following this Barney criteria for symptoms and even given criteria for almost all vestibular disorders. And according to them, there are 4 different symptoms, that is vertigo, dizziness, vestibular visual symptoms and postural symptoms. And vertigo simply means that is sensation of a self-motion when there is no body movement, when there is no self-motion, or a sensation of a distorted self-motion. This distorted in the terms of velocity or direction. Patient will be moving in one velocity, you will feel that he is moving in another velocity, higher velocity, like that. And dizziness, on the other hand, is an impaired spatial orientation. There is no movement, sense of movement or subject moving or surrounding moving. There will be just a spatial orientation impaired. And it will be very difficult for the patient to explain that. They will be feeling that dizziness, but they could not put it into words. Then we understand that they are telling is dizziness. And vestibular visual symptoms include this visual symptoms that usually result from vestibular pathology. And postural symptoms are those symptoms related to maintenance of a stable posture. And coming to subcategories of these symptoms, like this vertigo and dizziness have almost same subcategories. Even though the codings are different, they have the same subcategories. These are spontaneous or triggered. This trigger may be either position change, positional, and positional means it occurs after the change of position of head with respect to gravity. Another one is head motion, that is occurring during the change of head position. And visually induced vertigo is there, where this a large, complex, distorted, large field object like a moving train or a large truck which moves in front of you will induce vertigo. And there are sound induced, Valsalva induced, orthostatic and all. Then vestibular visual symptoms, and here comes the external vertigo. External vertigo is actually the patient's perception of his own nystagmus. Nystagmus usually, common nystagmus, jerk nystagmus usually have a slow phase and a fast phase. This slow phase the patient will see as the surrounding is moving to one direction. And the fast phase, this subject will be cortically blind. So he will see just like this, a unidirectional movement. And when this is bidirectional movement, and that is called as an oscillopsia. That mainly seen in bilateral vestibular failure. And there will be visual lag, visual tilt, movement induced blur and all. And postural symptoms are unsteadiness, directional pulsion. This unsteadiness will not be having any directional preference. They will be just feeling unstable, okay, or a feeling of imbalance. Directional pulsion means if there is a directional, particular direction, like lateropulsion, antropulsion, retropulsion and all. There are balance related near falls and falls are also in the subcategories. So how to reach a diagnosis? We need a proper targeted history. There are different approaches, I just mentioned one. And the clinical examination. Clinical examination, vitals, starting from vitals, pulse, BP. BP should be taken in supine position and standing up position after 3 minutes, 5 minutes, 10 minutes, 20 minutes to rule out orthostatic hypotension. And detailed otologic and neurological investigation, examinations. A neurotological examination like C4 nystagmus, post head shake nystagmus, head impulse test, alternate cover test for seeing skew deviation, positional test, stability on form. Stability on form means patient will be asked to stand on a pliable surface and the proprioception will be denied. And we'll ask the patient to close the eyes so that vision also will be denied. He will be solely dependent on the vestibular system for his balance. And the investigation includes this audiometry, caloric test, VNG, WEM, rotational chair posterography, and except for this rotational chair posterography and DVA, I have not included this, all this, our Lakeshore has all other investigations and examination being done. And WEM is already it's planned to come in 1 or 2 weeks along with the BERA. This WEM will also come to our hospital so that we can, Vertigo Clinic can proceed with doing WEM. And all these clinical examination things can be done by a single instrument or equipment, that is a VNG, video nystagmography. Video nystagmography, simply the subject will be examined with a set of goggles and illuminated with infrared light. Infrared cameras capture the video of eyes and it detects the center of the pupil, and pupil movement will be recorded and plotted as a graph. And the simple thing about the graph is any rightward movement or upward movement of eye will be recorded as a positive wave, and any leftward movement or downward movement will be recorded as a negative wave. If the eye is standing still, there is no movement, it will be a straight graph. Also, the speed of eye movement will be denoted by the slope of the graph. Very fast component will be a steep curve, a steep wave, and the slow component will be a sloping. So I will just try to show you the common nystagmus pattern. If it is, this occurs occurs as a small slow component, and it is moving up means either it is right or upward. Then this is the fast component. So this is a left beating or down beating nystagmus, and this left beating or down beating nystagmus will come like this. The slow component will be to upwards, and the fast component will be to downwards. Similarly, left beating nystagmus, right beating nystagmus or up beating nystagmus will be like this. The slow component will be towards down, and the fast component will be like this. So with a VNG we can see for saccades, smooth pursuit, optokinetic, spontaneous nystagmus with and without optic fixation, and gaze that also with and without optic fixation, fistula test, Valsalva head impulse, high frequency head shake test, all the positional test, caloric test, VOR suppression. And this is the interface of the VNG machine that we have in our hospital. And this is a few examples of the VNG graph just to see. And here we can see black and purple. Denotes the vertical movement, and red and blue shows the horizontal movement. This graph shows a upbeating nystagmus. It's like this. The vertical component is showing upward movement, that is the upbeating nystagmus. Similarly, this is a post head shaking nystagmus, and this part that we are seeing is the head shake. When we shake the head at 2 Hz for 10 seconds, and after that any latent nystagmus or any hidden nystagmus, compensated nystagmus, and all will manifest, and that nystagmus will be recorded here. This post head shake, and this shows a nystagmus in the obeying the Alexander's law. This shows that a left beating nystagmus, and when the gaze to left, left beating nystagmus is there in neutral position, when there is gaze to left, that is this part, and after that the intensity of the nystagmus will increase, or the slow phase will be, velocity will increase when we look to the left side. And after that, when you look to the right side or opposite side, the intensity will decrease, or the slow phase velocity will decrease. This is called Alexander's law, and it's usually followed by this peripheral vertigo, mainly vestibular neuritis and all. And next we will see about another topic, that is the benign paroxysmal positional vertigo. BPPV is very easy for a doctor to detect and diagnose and treat, but it will be very difficult for the patient. During the first episode of BPPV, he will even feel that like an end of a world. And this, there are 3 semicircular canals. Just about the anatomy, there are 3 semicircular canals: anterior, superior, anterior, posterior, and lateral. And there is an ambulated end and a non-ambulated end. This ambulated end have a crista and a cupula, and the utricle at the center have a macula. Over the macula is this otoconia. Whenever this otoconia gets dislodged into any of this canal, there occurs the BPPV. So, as I told, there are 3 semicircular canals, and the semicircular canal mainly responds to this angular acceleration and deceleration. This endolymph inside the semicircular canal usually have the same density of the cupula, so it won't respond to gravity normally. But whenever there is an increase in density or decrease in density, or where there is a debris in the canal, then it will cause an aberrant activation of the semicircular canal and vertigo. And we can see in this diagram and in this video, that is a debris moving inside the canal will cause aberrant activation of the canal. And one common mistake that we have been all following is thinking that BPPV means positive Dick-Salping test. No, BPP is not equal to positive Dick-Salping test. Dick-Salping test is only a diagnostic maneuver for posterior canal canalolithiasis. Similarly, there are other canals. There are anterior, there are lateral, and canal and cupula. And we have manuals for all these. These are less known and not routinely done in general practice. So I'll try to shed some light into other canal causing BPPVs, like lateral canal. Lateral canal is the second commonest canal involved in BPPV. It can be either canalolithiasis or cupulolithiasis. Canalolithiasis means the debris will be inside the canal, and cupulolithiasis means the debris will be stuck to the cupula. So the diagnostic test for this is called the supine head roll or McClure-Pagnini. We'll just make the patient lie backwards with the head flexed to 30 degree, and we'll just turn the head to one side and look for any nystagmus. Again, we'll bring the patient back to the neutral position and turn to the opposite side. And what that they will show now, bring back to the neutral position, and they will repeat it on the opposite side and look for the nystagmus. So there are two types of nystagmus will be noted. One is geotropic and one is apogeotropic. That's very simple. Like if the patient is looking to right and there is right beating nystagmus, and looking to left and there is left beating nystagmus, then it is called a geotropic nystagmus. And when the patient look to right and there is left beating nystagmus, and there is left looking to right and there is left beating nystagmus, then there is apogeotropic nystagmus. So this geotropic occurs when there is canalolithiasis. Apogeotropic occurs when there is cupulolithiasis, when it is stuck to the cupula. And the treating manner is also different for both. This canalolithiasis is treated with Guffoni maneuver, and unlike Epley's maneuver, it can be done like patient will be sitting, he will be brought suddenly to the opposite side of the affected ear, and head will be turned downwards. That also a rapid movement, and he will stay there for 30 seconds, 2 minutes, and after that he will be brought up. This will treat the canalolithiasis. If it is cupulolithiasis, it's opposite of this. That is called as an Appiani's maneuver, and this Appiani's maneuver will convert this canal cupula to canalolithiasis. That is, the debris will fall from the cupula to canal, and then we will treat it with the Guffoni's maneuver. And next is anterior canal BPPV. Anterior canal BPPV is very rare because of its anatomical position. It will be difficult for the debris to stay there in the canal, so it will automatically fall into the vestibule most probably. And the therapeutic manner, the diagnostic manner is supine head extension, and therapeutic manner is Yakovenous maneuver. I am not going to the detail. Next we will have the posterior canal BPPV. Posterior canal BPPV is the most common BPPV. Most common canal involved is the posterior canal, and we are usually doing this Dick-Salpik maneuver and Epley's maneuver for correction. Dick-Salpik maneuver, the patient will be turning to head to the one side and lie down with the
head is moved in such a way to manipulate the distal to fall towards the canal opening.
We will look for the torsional nystagmus, torsional and vertical nystagmus. After that, we will put the head to the neutral position.
If turns are made before
this is they are continuing with the Epley's maneuver. Since they found the nystagmus, it is positive Dick-Salpik, and they are completing with the Epley's maneuver. You can also see the movement of orthoconia when we are doing the maneuver. And ultimately it will fall into the vestibule. So I'm just ending my presentation with the small, very easy case. Like this patient was referred to us on October 14th from medical oncology floor, like 5th floor. She was a 54-year-old female non-case of ear breast referred from medical oncology with acute onset vertigo triggered by lying down and turning to left. It's a very straightforward case. Each episode lasted for a few seconds and was associated with nausea and vomiting. General examination, neurological, otological levels all normal, and we straight away went for a Dick-Salpik test. And with the VNG, the Dick-Salpik test was negative. There was no nystagmus on the Dick-Salpik test. Luckily, we did the McClure-Paganini test, and the video on the graph comes like this. When we turn the head to the right, there is a small intensity, low intensity right beating nystagmus when we turn the head to the right with 30-degree flexion. And when we turn the head to the left in the McClure-Paganini, there was a very high intensity nystagmus, high intensity, high velocity nystagmus when we turn the head to the left, and that was left beating nystagmus. So it was a geotropic variety of lateral canal BPPV, and which we managed by doing the Guffoni maneuver, and the patient need not take any other drugs for this. That maneuver itself is end of the treatment. So thank you for listening. Hope you had something to take home from this presentation. Like there are other maneuvers other than Dick-Salpik, and there are these terms should not be used interchangeably. It has got some meaning for itself. You can always refer to the Baronese Society criteria. It's very well written. Thank you.
Thank you, Dr. Gokul. Now may I call upon Dr. Shwetha Shenoy, the young dynamic doctor of the law, to present a few cases of vertigo.
Good morning, everyone. On this morning, all of you have found yourself right in the vortex of a vertiginous talk. So to start with, balance is multidisciplinary. Balance is a multidisciplinary phenomenon, which is why approach to treatment of balance disorders has to be multidisciplinary. If there is a poster child for a multi-speciality hospital it is vertigo. Before we go any further, I'd like to thank everyone who's taught us what we know, and all those who put their effort into propagating science, pave way for the next to take a step further. This is the kind of multidisciplinary interaction that we speak of when we speak about vertigo. Balance has to be maintained, which is why so many different systems come together to achieve this, which is why so many different systems can also come together to disrupt it. The mains that we talk about are mostly eyes, the ear, that is the vestibular system, cardiac, CNS, central nervous system most importantly, but a lot of common conditions that involve nutrition, joint health, hormones, vascular conditions, spinal cord conditions, all come together for the perfect maintenance of balance. Before we go any further, I'd like you all to do a small experiment right here. I want you all to hold your hand in front of your eyes. And first, move your head really fast. Can you identify the outline of your hand very clearly? If you cannot, we'll see you tomorrow in ENT OPD. But can you identify the outline of your hand really clearly? Now try holding your hand, try holding your head still and move your hand. Can you see a clear outline of your hand? No, you cannot. So this is what vestibulo-ocular reflex is. If a cheetah can see its prey in spite of moving at this speed, it is because the eye and the balance organ in the ear work together to keep vision in sharp focus. Ultimately, the role of this entire balance system is so that humans can walk upright. If every time we move our head, the image loses its foveal contact, you are going to fall down because it tends to make a person imbalanced. So the whole idea is to make sure that the image is on the retina at all times. And there is a series of movements which are set into action, which are guided at different places in the central nervous system, like the eye, the intraocular muscles, or oculomotor nucleus at midbrain. There is something at the level of pons. There is more inputs at the level of the brain. So each point of this pathway can lead to issues in balance. So we start with some cases that we have seen here, which we thought were ENT cases, which we thought were pure peripheral, turned out to be central, which we thought were central problems, turned out to be peripheral, which drives the point that, again, vertigo is multidisciplinary. So this is a reference we got from gastromedicine. The patient's history was, I cannot walk because of vertigo. This is a 65-year-old male who was diagnosed to have cirrhosis since 2011, presented with fatigue, slurred speech, dizziness since 1 month. He had episodic, that is on and off, non-triggered. He doesn't need to move, sit, stand, any kind of trigger to develop this sensation. It worsens when he walks, so he was wheelchair bound. He stopped consuming ethanol nearly 10 years ago. On and off, when he was consuming, he had episodes of decompensation where he had encephalopathy. He was admitted in ICU some time back at a different place with pneumonia, diagnosed with ICU psychosis, was started on various psychiatry medicines. But when we saw him, his eye movement, saccade is a movement where the eye goes from right to left and left to right. So this movement was pretty much normal. Smooth pursuit is when you look at an object of interest with the intent of looking at it and not taking your eyes off it, and you watch it go across. So that is Sakai. So his smooth pursuit that is smooth pursuit. His smooth pursuit showed a step ladder like pattern. This is the target, and this is how his eye is moving in a step ladder like pattern. So when we say he had spontaneous nystagmus, so this is his eye. When we remove light, we are removing the eye's contribution to fixating. So once the eye's contribution to fixating is removed, it's only up to the brain and the vestibular system to hold the eye in its place. And if there is a deficiency in one of these two, the eye will deviate. So here is a patient whom we saw who has a typical downbeat nystagmus. That is, his eye moves downwards. It's a very subtle movement, which is why we need this nystagmogram to show us, because bare eyes cannot see this. So in each of his gazes, we found the same nystagmus. So downbeat nystagmus is very pathognomic of these conditions. And our patient had ethanol abuse. He was on anticonvulsants. It could be paraneoplastic syndromes. There are many other degenerative disorders in where we get a downbeat nystagmus. So we thought it could be Wernicke's, and he was given high dose of thiamine and tapered over 3 days. And he could walk on day 2. On day 5, he started walking with minimal support. So this is a nutritional deficiency which led to vertigo. So we did the readings again after giving him thiamine, and it showed absolutely no nystagmus. So this goes to show that thiamine is a very important cofactor in the generation of in the generation of glutamate, GABA, and aspartate. These are all neurotransmitters, and their absence can lead to astrocyte cell death, leading to a degenerative neuropathy. Now the next part was, we had confirmed this, but he had stopped alcohol 10 years ago. So ideally he should not really be progressing so fast. So he had some other trigger. His CT abdomen showed a foci of hepatocellular carcinoma, getting us back to this point where malignancies have increased basal metabolic rates, can also induce thiamine deficiency. Not only in this case, in any kind of cachexia, there can be a coexisting nutritional thiamine deficiency, leading to a balance problem. Now, for why did we see downbeat nystagmus? Again, it is because of a lower brainstem involvement in Wernicke's. Our next patient came from nephrology. Her symptom is, my head starts to spin all of a sudden. There are no triggers, she doesn't bend, there's nothing to suggest there is postural hypotension. She's sitting having a meal, and suddenly her head starts to trigger. She starts feeling vertiginous sensations. So this is a 66-year-old lady with chronic kidney disease on maintenance hemodialysis. She's on 2 sittings per week. She's awaiting a renal transplant. She's diabetic hypertensive. She has sudden rotatory vertigos lasting from few minutes up to few hours. This can happen untriggered most of the time, but occasionally positions tend to worsen. She has a sensation of oral fullness. Oral fullness is like suddenly if there is water in your ear, that kind of sensation. And fluctuating hearing loss. This was actually what was important, where she says that her symptoms are worse on days leading to dialysis and then gradually settles down. Post-dialysis days are far better than pre-dialysis days. Initially she had hearing loss, but now in the lower frequencies, but now she has hearing loss across hearing range. But her gait is okay, she's able to manage herself. So this could be one of the following: our manias. It could be an episode of sudden migraine where it manifests with vertigo more than with headache. TI, it could be BPPV, those episodes that were triggered. So her examination showed a horizontal nystagmus. Again, we have to do this without fixation. We can't do this when she's undergoing a dialysis. So the maximum we can manage was an hour after dialysis. So you can see that her eyes are moving in a horizontal pattern. So why does this happen? So this happens when the right and the left balance organs are not functioning at tandem with each other. If one balance organ functions less than the other, the opposite side is overactive at the level of the brain. So that is why the eye moves preferentially on one side. And so this was a patient who had Meniere's disease, but it was secondary Meniere's because the fluid accumulation was a part of her kidney disorder. She was already on diuretics, which is the treatment for Meniere's, and clearly it has not helped. She's on fluid restrictions, so we cannot ask her to hydrate at will. And this recurrent worsening of electrolytes causing on and off imbalance. We would have liked to give her intratympanic steroid, but any kind of intervention just prior to transplant would not be ideal, especially when we look out for perforations prior to transplant. We mustn't be the people inducing one. So the best thing that they did was they changed the dialysis to 3 times a day. So sometimes treatment of vertigo is done by chance also. Once her dialysis was shifted to 3 times a day, her vertigo stopped, which goes to show that there is a huge similarity between how the kidney and the ear functions. Both are membranous structures, both have tubular organization. The homeostasis depends on the blood flow that runs through it. Vasoconstriction has such an important role to play on both sides. The vascularization on both sides is terminal type, which is why damage can be permanent. And both are very sensitive to vasopressin receptors and neurohormonal processes. This is someone who is selectively ENT, but it highlights the need for rehabilitation and the value of having a good physiotherapy department. We have a 56-year-old lady, post-COVID infection, comes with vertigo. Initial days were very bad when her eyes would move like this without light. A person with such rapid eye movements cannot expect to maintain adequate balance. So this is the way her eye functions. You can see it is selectively going to one side. That is the healthier side. So she was diagnosed with vestibular loss, probably COVID induced because it's a viral infection. She was started on steroids, supportive medication, started on vestibular rehabilitation, and this was no nystagmus after 1.5 months of intensive rehabilitation. Having said that, once there is one side functioning less, it is only a matter of time that she decompensates and gets her next attack. So this can be checked whether this is a compensatory version of stability or no by gently moving her head back and forth, where you can see her eyes moving, and you can induce that nystagmus that was absent again. So this proves beyond doubt that she has a unilateral dysfunction, compensated, but a simple journey like a long ride or a long car journey, bus journey can decompensate her and get her back to the previous vertiginous state. This is the last one. So this is a patient who came to ENT and had all 3 problems. So his symptom was I had sudden giddiness and I fell down. I also have ear discharge. The one time ENT surgeons hear ear discharge, we are convinced beyond doubt this is our baby. But 84-year-old male comes with sudden drop attacks lasting for a few minutes. Post-drop state is near normal. He has ear discharge and reduced hearing. There's a perforation on the tympanic membrane. So we thought of either a TIA, a otolithic drop attack, or a cardiogenic cause. So we sent to madam and she did an MRI which showed a cerebellar infarct. And due course of examination, his heart rate was 42. So he went to the cardiology department and it was found that he has symptomatic AV block with probably due to degenerative conducting system disease. Second type 2 secondary degree AV block and a pacemaker insertion was done. Could it be the stroke causing vertigo? Could be, because it's in the cerebellar region. Could it be, it could be the stroke causing baseline dizziness, the hearing issue causing hearing loss, and the cardiac issue causing the syncope. So goes beyond doubt that vertigo is multidisciplinary. So this is a very famous game played by all kids where all of them rotate round and round. So here are all of us multidisciplinary people in vertiginous motion with the kids. We're just hoping it is not husha busha all for you. Thank you.
Thank you, Dr. Shwetha. That was quite illuminating. Next, we have Dr. Lakshmi Ranjith, who is a new addition to our department to talk about cochlear implant, which is her specialty.
Good morning, everyone. Last talk today, so I'll try and keep it short so that we can run for breakfast after this. So what we are going to discuss is what hearing loss is, how we manage hearing loss, who benefits from cochlear implants, and a short word about universal newborn hearing screening program and why we need it. So one of the most famous differently abled people we all know of is Helen Keller. She was both blind and deaf. So this is what she said once, that blindness cuts us off from things, but deafness cuts us off from people. I just want to show you a short video. That's not a technical glitch. The video is muted. I'm pretty sure none of you understood what was happening. Now we'll see the video with the sound on.
So when I was really young, probably kindergarten or first grade, I have a much older brother.
Now we'll see the video again in mute. So what happened the second time? I'm pretty sure some of you could at least catch a few phrases of the video when it was played in mute the second time. That is post-lingual deafness. That is people who have developed speech and then gone deaf. They get some help from lip reading. While the first time what happened is something equivalent of prelingual deafness. Children who are born deaf, they have no idea of language or its syntax. So trying to make them understand speech is very difficult because they have no idea what we are talking and it is just random actions that's going on around them. They don't know that we are even communicating with each other. So hearing loss is the most common sensory deficit in humans today. WHO estimates that in India there are 63 million people who suffer significant auditory impairment. So this is a good deal of hearing loss, not moderate. There are lesser numbers who have milder hearing loss, and a very large number of this is children. So that means loss of productivity for our country in the future years. 30% of all the hearing loss is due to old age. Adult onset deafness is around 7.6% in our country and childhood onset is around 2%. The sad part is that half of this deafness is preventable and 30%, even though not preventable, is treatable or aidable. So this is just a map which shows that the Southeast Asian region accounts for around 100 million deaf people. That's a huge number. So what is the impact that hearing loss has on people? Some of it a lot of us are aware of, but some we don't think of. Listening and communication is a given. Obviously, if we don't hear, we cannot communicate. And that way, COVID has been a very big bane for people with hearing loss, much more than what it has been for the others, because masks exacerbate their problems because they do not get cues from lip reading anymore. And even social distancing, all this has increased their trouble of hearing loss. Language and speech, like we just said, unless a kid hears, he will never develop language. And the outcomes in these children are much better with earlier intervention. Now these two things we probably know of. There is something that we don't think of is cognition. Unless people can hear, they have a cognitive decline. So there is always a cognitive delay in children who do not hear. And now it is proven beyond doubt that hearing loss in adults is the largest potentially modifiable risk factor for age-related dementia. Mental health. People who don't hear, and especially those who don't use hearing aids, they tend to keep away from social gatherings. So their loneliness increases, and now it's a proven cause for depression and anxiety. What about relationships? 90% of children are born to hearing parents. So parents do not have an effective way to communicate with their own child. Among adults, it can lead to communication difficulties, misunderstandings, conflicts. And this is one of the most important points, especially in our society. The stigma that is associated with hearing loss is tremendous. People, even when they are diagnosed, refuse to use hearing aids. I keep telling a lot of patients, no one has a problem using spectacles, but people have a big problem using hearing aids. And I'm pretty sure that stigma is there even among us. So if you all ever see old people, especially who have difficulties communicating, please encourage your patients to start using hearing aids. It makes everyone's life much easier. So what are the causes of hearing loss? There are many causes. From the time that you are born till the time you die, there are different causes. It is just how we identify it and how we treat it first. One cause that I want to highlight here is sudden sensory neural hearing loss. We have patients who come to us who tell us that I got up today morning and I can't hear from one side or sometimes even both sides. So it is a sudden decrease in their hearing threshold, which happens usually within a 72-hour period. Why this is so important? It is a medical emergency. Unless there is some other cause to it, it is usually an idiopathic loss, and it can be treated if caught early with corticosteroids, either oral or intratympanic. So this is the grading that is given by WHO for hearing loss. So usually it is the severe to profound category that we use cochlear implants in. WHO has also given a separate category for unilateral hearing loss now, which none of us consider very important. Why they have done that is because we need 2 years. There's a reason we have 2 years. One, it helps us to know the direction from where sound comes. And the second, the probably more important effect is called the squelch effect, where there's a large gathering and you need to listen to one speaker alone. Like today, you need 2 years. That cannot happen if you have only 1 year functional. So this becomes very important for children when they go to schools and colleges. When there are children around them talking in the classroom and they need to listen to the teacher, they need to have 2 proper functioning years. So how do you prevent hearing loss? Over the course of your life, again, we all know a lot of this. There is immunization like rubella for young girls and women that can prevent congenital rubella syndrome, or frequent checkups in school, and across life for old age, we need to have hearing checkups. Then obviously with all the increased noise in our environment, there is a problem of hearing loss. Then mobiles, all our Bluetooth, speakers, everything that contributes to increasing hearing loss. As medical professionals, one thing that we need to be aware of is ototoxic drugs and how to use them judiciously. Now, how do we manage it? Depends on what kind of hearing loss it is, whether it is conductive, whether it's sensory neural, and depending on that, whether we do surgeries or whether we aid them with hearing aids and give them rehabilitation, depends on what loss we are seeing. So what are cochlear implants? A cochlear implant is basically an electronic device that we implant surgically that converts sound energy into electric energy. That is how it is different from a hearing aid. A hearing aid only increases the volume of sounds, but a cochlear implant will pick up the sound, convert it into electrical energy and give it straight into the cochlea. It has usually 2 components. The external device and the internal device. The external device will have the mic. The internal one will be implanted right into the cochlea, and that will give the electric signals to the cochlear nerve. That is why patients who don't benefit with hearing aids also definitely benefit with cochlear implants. Now, what is the candidacy? All children with congenital or acquired profound hearing loss. Like I said, severe to profound is the category we usually use for cochlear implants. And in the case of children, the earlier the better, because if their auditory deprivation is too long, trying to develop speech will be a problem for them. All adults with bilateral profound hearing loss of for any reason, they will all benefit with cochlear implants. Now, as cochlear implants are going up, even their candidacies have expanded. Now we are doing children of younger age so that we catch them sooner. In India, we have started doing children of even 9 to 10 months of age, we can implant them. In UK and all, they have started doing implants for children even 6 months of age. Bilateral implants are becoming the norm now. Like I said, 2 years better than 1. Even for problems like auditory dysynchrony, where there is a problem with probably the inner ear, even their cochlear implants help. Syndromic deafnesses also, cochlear implants are very, very useful. Even though it may be more dangerous to implant or maybe more risky to implant such children, but especially children like Usher syndrome, where they have a hearing loss and later they develop blindness as well. So at least if we restore their hearing, that person will be able to survive in society. And like I said, now even unilateral hearing loss, we need to start thinking of cochlear implants. Now a small word, especially for my pediatric and neonatal colleagues, on universal newborn hearing screening protocol. Why do we need universal newborn hearing screening, not risk-based screening? Because 6 out of 1,000 children are born deaf, and without screening, we will not identify them. They'll be missed. By the time the parents identify the hearing, they are already 1.5 to 3 years of age, and we have missed a very big window to help them develop speech. So, a newborn hearing screening program will help us identify these children early, treat them early, and mainstream them early. So, what is the timing of screening? There's a rule called 1-3-6. Every child born should be screened by 1 month of age, and if we find any abnormality in their screening, they should be diagnosed by 3 months of age. We need to have a definite diagnosis of why they are having a hearing impairment, and by 6 months we should have intervened. Now if there's a profound loss, we may not be able to do a cochlear implant at 6 months, but we should at least give them hearing aids by 6 months, so that their auditory cortex remains active. So when we do an implant later at 9 or 10 months, we get better results. So this is the protocol that we need to follow. All newborns can be divided either into babies who've gone into the NICU or they are well babies. Well babies can be just screened with autoacoustic emissions. That is just testing the outer hair cells. It's a non-invasive test and it's a very short duration test. Only those children who get a refer on autoacoustic emissions should probably be screened with a BERA or a brainstem evoked response audiometry. But NICU babies, because they have other factors like maybe low birth weight, hypoxia, hyperbilirubinemia, all these are factors that cause hearing loss. They have to be screened by both an autoacoustic emission and a brainstem audiometry response. And if any of these, even one of them is a failure, we need to completely work up the child to see why the hearing loss is. Now, why all this, this thing of pick up early, treat early? Because I want you to see this video. This is a deaf lady who's not had any hearing rehabilitation. She's trying to talk and the person in front of her is trying to understand what she's saying. So she was trying to say pumpkin all this while, okay? And this.
That my friends are 4. And first one is Sai is my friend, and Anand is my friend.
This is a born deaf child. He had a bilateral cochlear implant early in life. That is his speech. That is what we are trying to achieve. Now for those of you who missed this video, this is a clip from the switch on of the child that we implanted a few weeks back. This is his switch on, so it's the first sound he hears in his life. So basically it's a new sensation. We don't know if he is perceiving the sound or not. And then later, of course, he gets scared because these children have never heard this ever in their life. So when they hear this first sound, it's a new neural sensation, so it takes some time for them to get used to it. But slowly and surely, we are hopeful that he will also be able to talk like the kid in the last video. That is why we need cochlear implants at an early age. Thank you.
Thank you, Dr. Lakshmi. That was an excellent talk. And now just to conclude from the initial talks, we have seen that patients with vertigo may land up in the office of a neurologist, an ENT surgeon, a cardiologist, a physician, or even to a psychiatrist. So anybody will be confronted with this problem. So when a patient tells that he has vertigo, he may be meaning dizziness, he may mean a true vertigo, he may even mean a true loss of consciousness. Now, it is the responsibility comes to rest on the physician's shoulder as to clearly identify the varied causes of vertigo or balance disorders. Now, I would just conclude by summarizing 2 points, 2 dangerous causes for balance disorders or vertigo. One would be a posterior circulation stroke when the patient, a middle-aged person or an elderly patient with vascular risk factors like hypertension, diabetes, or dyslipidemia is presenting with vertigo with some associated symptoms like, say, dysarthria, diplopia, hemiparesis, etc. The first diagnosis that we will have to entertain is a posterior circulation stroke. The second one is, again, when a patient comes with dizziness or giddiness, and you look at the pulse, and it is tachycardia or bradycardia, say less than 40 or more than 170 usually, then it is pointing towards a cardiac dysrhythmia, so prompt referral to a cardiologist is essential. Then from a neurologist point of view, we have certain seizures, vertiginous seizures, where you have something described as a tornado-like feeling, described as a tornado epilepsy, where the patient has a seizure originating from the temporal lobe, and the patient comes to you with episodic or paroxysmal, rotatory or spinning sensation. So prompt recognition of vertigo would be very much helpful in the prompt treatment of these disorders. Now the floor is open for discussion, open for queries. Thank you for your patient listening.
I think I enjoyed the presentations very much. I have a couple of questions and a comment. The first is, how do you really look at dizziness or giddiness? Patients describe as though the lights are being dimmed in an auditorium. Sometimes it goes on to syncope, but then it becomes maybe a circulatory disorder, but sometimes it doesn't. And how do you really understand this? This is a common symptom even in our surgical wards and in our outpatient clinics. And it's sometimes hard to put a finger on it.
This may be like a graying of vision, isn't it, sir? So then it may be implicating a hypoperfusion of the brain. First we have to check the pulse, then the BP. Mostly the patient is going to have a hypotension, anemia, or a bradycardia or a tachycardia. So these would be the initial things that we have to look into when the patient has something like a graying of vision, which we would classify as a lightheadedness. Pre-syncope. This patient, if not treated promptly, will go in for a syncope.
The second question was regarding, say, bone conduction headsets. Apart from allowing ambient sound to enter the ear through the normal path, is there anything different in bone conduction as opposed to the regular conduction, say, headsets?
So bone conduction hearing aids we usually give for people who have a unilateral loss. So that they get to know direction. Like if there's a profound loss on one side, the other ear is functional, we can implant a bone conduction device and it will pick up sound from this side, give it to the cochlea of the other side, and that is how bone conduction works. Another place that it's useful is when there's a chronically discharging ear. So if there's a ear discharge, we can't give a hearing aid on that side because it will just worsen it. So only in such people, bone conduction devices are useful.
I think the question was regarding bone conduction headsets. which is a new thing in technology now.
No,
People
the quality of the sound is not any different.
It's the same.
It's not any
My
different.
comment was regarding Shwetha's remark about the Ringa Ringa Roses. This is actually a very macabre song, rhyme which was taken from the description of the Great Plague of London, and all fall down meant everyone was dying. And then they showed posies, which is supposed to be an antidote for plagues, perhaps not in tune with the wonderful presentations that you made this morning.
By the way, we'll be getting the Bera machine soon. So this new hearing programs we should start right away. We can now. I think people from IMA comes here once in a week or twice in a week, or once in 2 weeks or something. So we are getting a Bera machine and we can start that program.
Any more queries?
Is there any role for cochlear implants in old age hearing loss?
Definitely, ma'am. That is what we've been trying to tell people. Any person, we have, like my older institute now, we have done implants at 70 years and people have had a very uneventful and a happy life till 85, 90. Age is not a problem for implantation at all, because age-related hearing loss is a very big problem in our country now, and the main problem is the stigma associated with it. The only issue is it's like a hearing aid. It will be seen outside. That is the only thing that they have to agree to. And even there is some amount of rehabilitation, but that is there for children also, and since it's post-lingual deafness, it will be much faster. So within 3 months and all, they'll be able to hear like they were hearing in the beginning. Because a cochlear implant is obviously an electronic device, so initially the sound will be slightly different, but with 2 or 3 months of therapy, they will go back to normal. So there is a definite role of cochlear implants in old age.
And you talked about unilateral versus bilateral. Is it required, bilateral or unilateral is not?
Ma'am, bilateral and unilateral is just a financial issue, like because of the cost of the implant. Each implant, the most basic one also right now costs around 5 lakhs. So if they can afford it, everyone should do a bilateral implant. So there are costlier implants, each implant costing around 12 lakhs or so. So when patients ask us, we tell them you buy a 5 lakh implant and put it in both ears, because bilateral is any day better than unilateral. But if they can't afford it, at least unilateral, even in case of older adults or children, will help them have a normal day-to-day life. Like I said, the only issue is the squelch effect, which will be a problem, and directions, they may be slightly confused. But they can have a reasonably good life. But if they can afford bilateral, definitely.
Hi. Any idea about the neosensory buds? It's a new device which converts skin into cochlea. Heard about it?
No. Sorry. But
Dirty white hair.
You can say
What
something
it
more
does
about
is
it.
basically sound is vibrations. It's worn on the wrist or some part of the skin, converts, amplifies these vibrations, and the skin starts perceiving sound.
so probably I don't think if the cochlea doesn't work, this is going to work.
Yeah.
Because so this is similar to bone conduction devices, what we use. Like I said, if one side the person has severe hearing loss, you can pick up sound from there and give it to the other cochlea. That also works on the principle of vibration. So anywhere in the body, if you have a vibrator, probably the sound will get relayed. But that is provided your cochlea is working.
This is the advantage of this is it's only a few $1,000s.
Yeah,
The
so
costs are very low, and as I understand it, it's used. The sound is perceived by the skin, not by the cochlea.
okay, I have not heard of it.
No, the sound is perceived and conducted to the cochlea. Ultimately, it is the cochlea which conducts the sound to the brain.
Actually, such a thing is used for dizziness. It's called a vestibular belt. So it is sort of tuned for that person's posture and balance. And every time there is a slight off balance or it goes, the patient's gait starts to shift. It gives a buzz, prompting them to correct their angle of postural imbalance.
One question I would like to ask. Like talking people are sitting on the dais, Has anybody come to you and said, I wish I were born deaf?
There's a study somewhere which says that people who are elderly and who are deaf have enjoyed much better health because they don't hear all the BS that the world throws.
Yeah, I know.
I think the robustness of the discussion indicates the fact that many people have personal hearing difficulties. And when I say hearing, it's just not the physical hearing, but the listening. Most of us don't listen to each other, and perhaps it's a good idea to start listening.
Deviating from this cochlear, all those things, there are, I mean, it is regarding the post-COVID sequel, many people come with tinnitus. So how do you deal with it? And what is the mechanism behind it?
So tinnitus is multifactorial again. It starts with slow death of the outer hair cells in the ear, because like I told that the cochlea is an end organ. So during COVID, in case there has been a we have seen vascular issues in COVID. So it can affect the inner ear as well. So tinnitus comes from either outer hair cell or inner hair cell dysfunction, or there is a form of pulsatile tinnitus where the nerve and the vessel is in close proximity to each other, so increase in blood flow through that vascular loop causes tinnitus. In this case, it's mostly a imbalance in the ear canal. Tinnitus is not curable. That is one thing we have to understand. Tinnitus is not curable, but with biofeedback therapy, the sound can be reduced. The perception of the sound can be reduced. Ear has its natural mechanism where we are able to tune into one particular frequency in like what she said, squelching effect, like one particular frequency. In this gathering, if someone's talking about me, my ear will directly go there. So the same thing is, if you pay attention to the tinnitus, the sound amplifies because more synapses are formed across that sound and that part of auditory cortex.
In addition, there are tinnitus suppressing hearing aids. That is one thing. And then there are some symptomatic treatment which we try. Mostly it may be a placebo, we don't know. But many people do say they are better. The tinnitus is better after maybe 2 or 3 months of especially ginseng and things like that. So they do respond well.
Is it because of the clotting of the vasculature to the vestibular system?
Basically, tinnitus is a symptom, right?
No,
so
no,
if
I'm talking about post-COVID.
Yes.
Yeah, so even there, anytime tinnitus is a symptom, it's not a diagnosis, right? So we need to see what the cause of the tinnitus is. And see, if there's a hearing loss, we treat the hearing loss. If we treat the hearing loss, the tinnitus settles down. So that's why there are many people who come this post-COVID also. There's a good chance that it is because of sensory neural hearing loss post-COVID that they're having tinnitus. In that case, start using hearing aids. If you use hearing aids, your tinnitus will come down. What is tinnitus? It's the sound that is made by the outer hair cells. And because we are not getting external sounds, we are not able to perceive. So that's why this tinnitus becomes louder. So if you address that issue, so like ma'am said, if it's a problem with the vasculature, if it's something that we can treat, we have to treat that, and that will help us fight the tinnitus. But as such, treating tinnitus is not possible. So many times when we don't know the cause, like if the hearing is normal, everything is normal, it's very difficult to give the patient some kind of, happiness that they're tinnitus, because then they have to take a conscious effort to, like she said, to not listen to the sound. Then slowly they'll get used to it.
Thank you.
One question regarding drug-induced hearing loss. How long you will be waiting after stopping the drugs for the recovery, and what is the criteria used?
So there is no consensus on that. There have been reports that even with just one dose of phototoxic drug also there can be. So we can't, that's why I said we have to use it judiciously. We can't tell you that, don't even be used sometimes. So it's just, and it doesn't, most of the time it doesn't recover. It's a permanent loss. Sensory neural hearing loss, once it happens, it's permanent. Like I said, the only thing is if we discover that it's a sudden loss, we can try corticosteroid therapy but there's no guarantee that it will come back. If we know that it's drug induced, like I said, if it's an idiopathic cause, many times there's a 60 to 70% chance that the hearing will come back. But drug induced hearing loss, unlikely that it will return.
In drug usage, the idea is to know that it can cause the hearing loss and look out for it. And if we stop the drug early enough, the chances that further damage will be prevented. So the idea, the main thing to do is that I'm giving such a drug that it can cause hearing and I should look out for it. That is what we should do.
Okay.
After a slap, some people have a ringing sound or tinnitus. How long will it last, or is it your reference?
After a slap, sometimes the eardrum breaks. That can heal. And when that heals, maybe the problem will be over. But if the slap has caused a sensory neural deafness, the nerve is damaged or the cochlea is damaged, then the situation is slightly different. Again, we go back to that tinnitus thing and cross our fingers.
Some say if you take 2 days, it will go off.
No, there is no system.
Eardrum repair?
No need to repair. Mostly traumatic perforation heals by itself.
Because my patients, after some of the patients, alcohol patients, they slap the wife. And they used to say some sound comes, then she used to say that I've fallen somewhere, and actually it is on the left ear. So I know that is the right hand which has hit the left ear. And I used to say, Adi engane undairunnu? Adi bhayangarayirunnu, sir. So it is how to say, whether to consult you for the...
Yeah, it's always, you are welcome to consult. Most probably but we have to keep the ear dry and periodically follow it up. If it doesn't show signs of healing, then we'll have to repair the eardrum.
So I think we'll conclude the sessions. Just before concluding the session, I just want to introduce our new doctors who have joined recently. So for that, we'll call our HR manager, Mr. Pradeep, to introduce the new consultants. So meanwhile, thank you, Idiculla sir, Dr. Bindu, Dr. Gokul, Lakshmi, and Shwetha. Thank you so much. Thank you. Over to you, Pradeep.